Okay, good afternoon and welcome to the MyDat session, the last of the month. Today I will be talking to you about something I presented Saturday in the digestive disease intervention in San Diego, California. The digestive disease intervention is a group of the SIR that dedicates to obviously to digestive diseases and involves all vascular and non-vascular procedures. And it has been a very interesting and positive meeting with great people involved there and a lot of good friends. So I will talk about percutaneous jejunostomy and cecostomy, which are basically procedures that are palliative, and are for distal decompression of the GI tract proximal to the site of obstruction. It allows the patient to get nutrition by mouth. The patient is obstructed, but you decompress them distally and they can eat. And patient selection is key for good results. So I will start how the story of the whole thing is, because the ileostomy is a procedure that I have described. And this is the first patient that trickled the fancy on how to, why could we use this, something we use in this patient in other patients. This is unbearable abdominal pain after small bowel follow-through. This is a 46-year-old woman. She was the wife of one of the faculty in ophthalmology at UCSD. This is the year 2003. No, 2003, no, 1993. She had ovarian cancer, had had multiple surgery for debulking, and episodes of chronic small bowel obstruction. So they wanted to do a small bowel follow-through to identify if there was any other mass or something that could somewhat do something palliative to help her. But when they did a small bowel follow-through, she got an obstruction of the colon by external compression and massive dilatation of the cecum. At that time, the colonoscopic guide couldn't pass, and the stents were not even thought of. This is 1993. So the OBGYN oncology surgeon asked me to do a cecostomy, and this is the X-ray of the patient at the time we did the cecostomy. The whole colon was exploding. The patient was having pain because he couldn't, the tension of the colon. And it was full of barium. Okay, so I did, like we do here, the gastrostomies, I did cecopexy. I fixed the colon to the abdominal wall and put a 14 French lock and pigtail catheter. What did I get? A spit of poop and barium. So I called the OBGYN oncologist and said, look, there is no way with the regular tools that I can evacuate this colon. So I used a urology set, the amplet set, dilated to 24 or 26 French, and put a malicot, and was able to irrigate and clean the colon. This patient we followed up, and at the clinic, and here we have changed the tube for another one, for a gastrostomy tube. She lived for 6 months as a cecostomy and was able to eat after the procedure. And she was, I would say, relatively pleased that she could enjoy something of life while she was having an incurable disease. Shortly thereafter, there was a patient, there was a librarian, very smart lady with a very dedicated husband, that had a uterine sarcoma, had multiple surgeries, had radiation, chemotherapy, and was living on TPN. She had 2 nephrostomies because the tumor occupied the whole pelvis, as you will see, and had persistent vomiting. As you can see here in this X-ray, this is a gastrostomy tube, but it's not a regular gastrostomy tube, it's a malicot. It's a big tube, okay? and despite that, she was vomiting. And you can see here the same image, and you can see here the tube surrounded by, these are small bowel loops. These are the nephrostomies. And this is kind of a little paraphernalia, but it doesn't have anything to do. This is all small bowel tube. Got a CT scan, and the CT scan, you can see the stomach is sandwiched between the dilated small bowel loops in the left upper quadrant and the liver. Therefore, the function of reservoir was lost. So every time she had an antiperistaltic wave from the small bowel, she vomited. Then down below, you can see down in the abdomen, this is contrast in barium in the colon, that who knows how old it was. It happens on all these patients that have chronic small bowel obstruction, that they have had contrast studies, and the contrast remains there. And this is the mass in the pelvis. You see, that's why the ureters were compressed, and the GI tract was also compressed, the small bowel in this case. So the treatment for chronic small bowel obstruction is usually palliative, after you did many surgeries and so forth, and this patient have had also radiotherapy, which prevents you from doing too heroic things with the intestine, because you have fistulas, and also had chemotherapy and so on. So the treatment is nasogastric intubation. Usually you have it for 1 or 2 weeks, because then local, problems at the level of the nose, prevents it from tolerating the NG tube. And then if you, also reflux is another issue, that the burnout so that of the reflux is a problem. Then you can do percutaneous gastrostomy, as you can see we have done in this lady. And this patient needs total parenteral nutrition with all the complications that it entails. So it's not a good solution, but it's the best solution for these patients to live as long as possible, because many of these patients, despite having intractable cancer, have a good performance status. So this is what happened, or you can see in a normal bowel pattern. You can see the ileal loops, the jejunal loops, the stomach there. But as you have seen on this patient, with the small bowel very dilated, the stomach is sandwiched, is squeezed, between the liver and the dilated bowel. And also, there is a big portion of the small bowel, proximal to the obstruction, that can be used for absorption. Therefore, if you decompress around here, in theory, the patient will be able to eat, which for someone that is vomiting constantly, not able to try anything by mouth, maybe a candy or something like that, is a tremendous improvement of her condition or his condition. So again, we have seen the CT scan, and I found that at this level, it was a small bowel loop that I could work with, and try to do the same thing we did for the patient with the cecostomy. So, and this is the first percutaneous ileostomy I've done, and here you can see, this is another mallecut from urology. This tail here, many of you are not familiar because we have not done too much urologic work. But when you do nephrolithotomy and you break the stones, we leave a tube that is a mallecut with a tail that is in the ureter, to maintain the access, And this was the NG tube. These are the nephrostomies. And this is the patient, after we did the procedure. Just was in follow-up. And the patient did well. So therefore, I had something interesting in our hands that we could work with. This case, the patient came quite close to each other. That's why I was very interested to do something, because a little kind of standardize a little bit the technique. So this is a 34-year-old woman, locally advanced cervical cancer, chronic small bowel obstruction, performance status 1. The patient was okay. The problem she had is she could not eat. She was vomiting constantly. and had a bending gastrostomy and transgastric jejunostomy that did not control her clinical situation. I need to talk about this a little bit, because if you have a bending gastrostomy and a distal obstruction, you know, putting a gastric jejunostomy is totally schizophrenic. Okay? It's not going to solve any problems. You're going to have another procedure. So you cannot feed someone when it is obstructed distally. So the CT scan shows the same as you have seen in the other patient. The stomach is here, has, in this case, a locking peak that they don't see very well because of the effects of the barium, you know, and the liver. Again, the stomach sandwiched between the dilated bowel and the liver. And this, again, the small bowel. But with my previous experience, and this is contrast in the column, with my previous experience, I said, piece of cake, you know? And this is what you can see here, the transition point, you know, dilated small bowel loops, normal bowel loops. So that obstruction was in the pelvis, but it had a lot of bowel that we could use. So for this case, I use ultrasound, you know, and we put, this is the needle, this is what we got out. Usually the content is all infected because of stasis, you know, and we injected contrast. This is the first puncture was with a T-fastener. We injected contrast, which proves that it is within the bowel. Put a wire, put an occlusion balloon, you know, bring it back to the skin, and in order to bring it back to the skin, this is a cross-table lateral. So this is the intestine, this is the airflow level within the dilated loop, and this is the abdominal wall. So I had a surface of the bowel in contact with the abdominal wall. Then we put 4 T-fasteners around the balloon to secure it. And here you can see the studies. This is in the right lower quadrant. Then we put a balloon backloaded with a sheath. Here you can see the waist of the fascia and the abdominal wall. And through the sheath, we put a catheter. And here is at the end of the procedure. This is the patient at the clinic, and this is how we change those bags. Notice that the catheter needs to remain within the bag. If you take the catheter out, that happened in one of our patients with cervical cancer to another cervical cancer patient, it tends to close. Despite all this and it pours out intestinal content, it tends to close. In any case, this is one case from here. Here I'm always bloated. This is a 55-year-old African American with intestinal pseudostructure. Are you familiar with intestinal pseudostructure? It's a very rare condition. It's a condition in which the patient doesn't have a mechanical obstruction, but the clinical presentation and everything is like a small bowel obstruction. He had a long history of abdominal distension, many surgeries. You know, surgeons that are not very familiar with this condition, they operate, cut pieces of bowel, colon, and so forth, but it doesn't improve anything. He had recurrent and unbearable intestinal dilatation managed by endoscopic decompression. Dr. Manas sent me this patient to me to decompress it with an ileostomy because he didn't have any colon anymore. But he was exhausted of doing colonoscopy, emptying the patient for every time because of the dilatation. This is an abdominal series with the patient supine, patient upright. This is all small bowel. This is the CT scan. See, well, this is the only patient that, you see, there's practically no colon. And we use, this is the patient, if you see, these are the loop of bowel. When you're looking here, those bumps, they are the loop of bowel. So this is the only patient we did it on the left upper quadrant, the left lower quadrant. See, we selected the area, we punctured, injected contrast, put the wire, the T-fastener, inflated the balloon, put the 4 sutures around, Okay? The balloon is in there, the waist, the balloon distended, the sheath coming over the balloon. Here is the sheath in place. When we remove the occlusion balloon, you can see what happened. This is the intestinal content, and this at the end. So this is the picture, the last picture of the procedure. This is the patient after we evacuated him. The patient decompressed the bowel by drainage, discharged 24 hours after the procedure, follow up at the minimal invasive radiology clinic. At that time, we had only one clinic for general procedures. So this was the patient before, this was the patient after. I was pleased with that, but knowing the biology of the disease was not expecting that was going to last for long. This is 2 weeks at the clinic, and this is a CT scan 10 weeks after the percutaneous ileostomy. He came back again with the same problem, And here you see our catheter, and the patient after that keep coming back again and everything. Someone interpreted it as a volvulus, opened it up, and did a surgical ileostomy, and the patient never left the hospital and died of tremendous decompensation because of the electrolytic disbalance, that constant pouring of intestinal content outside of his body. So percutaneous ileostomy indications: chronic small bowel obstruction in patients who are not surgical candidates, ovarian cancer, locally advanced pelvic malignancies, radiation enteritis involving distal small bowel, etc. One of the cases here is for a closed loop of bowel. Maybe some of you have helped me with that patient because that patient is relatively recent. The purpose is decompression of the bowel proximal to chronic ileal obstruction to allow patient to resume oral feedings. Contraindications: ascites, small bowel obstruction on multiple sites, that happened with one of our patients, and life expectancy less than 2 weeks. Because this procedure, most of these patients have recovered well and left the hospital pretty fast. Pretty fast meaning with less than a week. But if the patient is not going to live 2 weeks, it's too messy for them. Probably should be put on hospice. Best candidates: patient with chronic small bowel obstruction and good general condition that will enjoy at least what happened after. Long-term small bowel proximal to the site of obstruction so they can absorb what they eat. And if you have previous operation or radiation therapy. Why? Because we assume that the bowel will be stuck against the abdominal wall. So that gives you a prevention for peritonitis. So how you evaluate this patient? Per procedure imaging with GI contrast study needs to be hydrosoluble. CT scan of the abdomen to see, it helps you to select the small bowel loop. And image guidance sonography combined with fluoroscopy. The materials: percutaneous sutures to do the enteropexy, occlusion balloon, 8 millimeter catheter, just to bring a surface of the bowel against the abdominal wall, stiff guide wires, balloon 10 by 10 centimeters, catheter and sheath, backloaded, so it will allow you to put the catheter with no problems, and a Malacor or balloon catheter 24 to 30 French. Now in between we did this initial technique and everything, and just recently, a couple of years ago, they are working with a material called Axios. Axios is a way of keeping two surfaces connected with a hole in the middle. Okay, this is the whole thing deployed. This is a video that I plan to add to the presentation that I saw it by a guy on the Mass General that presented management of pancreatitis with necrosectomy through transgastric. And you can see here, and this is put endoscopically or percutaneously. Okay? And it has had FDA approved for transgastric cystectomy or cecostomy and necrosectomy. So the ileostomy, technically, you need to choose the ileal loop, puncture the ileal loop and do the enteropexy, balloon dilate the tract and catheter placement, and the catheter secured to the skin. Here is a diagram that shows you the procedure. Every time you're going to put a bag on a patient, electively for an ostomy, not when you drain it, then you need to drain it with a different outlook and philosophy. You need to put it in a place that the bag is going to be comfortable for the patient to change it or whatever. In the case of ileostomy, because the ileum most of the times and normally should be on the right side and in the lower quadrant, the right periumbilical area is the best. If you put it too low in the right lower quadrant, every time he bends or sits or whatever, the bag can have this function. But if you put it a little higher by the umbilicus, it's more comfortable. And you can see here the puncture with already loaded T-fastener. We have relieved the T-fastener, and you have this wire. I use amplets for this. Then we put the occlusion balloon deflated. We inflate the balloon, and then we put 4 more sutures around the balloon. We put a balloon catheter, dilate it, and then slide down the sheath, and through the sheath we put the catheter. The care for percutaneous ileostomy, you need to have an ostomy bag. The catheter needs to be irrigated to keep it patent, and we remove the suture in about 2 weeks. An elective catheter replacement initially 4 to 6 weeks after the procedure. The potential complications are peritonitis, transfixion of a bowel loop, abdominal wall infection that we have not had any besides the little inflammation around the tube, and catheter relation, which are the most common, occlusion and dislodgement. The challenges for the procedure is a ileostomy loop selection. You need to make sure that rule out multiple segments of small bowel obstruction. This is one of those cases. This is a patient with ovarian carcinoma that had dilated small bowel loops. This is before the procedure. Okay, you can see the dilatation here. This is after ileostomy. However, she had a lot of tumor, and then the relief lasted only for a month. As you can see, we have done only 9 patients, since 1993 to October 2016, because the year has not ended yet. We may have a case. And we were 9 patients, 6 women and 3 men. 6 were done in San Diego, 3 were done here. The mean age is 59 years, 43 to 74. 2 cervical carcinomas, 2 ovarian carcinomas, 1 each uterine sarcoma, endometrial carcinoma, prostate carcinoma, intestinal pseudostructure, postoperative closed small bowel loop in 1 patient. That accounts for the 9 patients. The relief of small bowel obstruction happened in all of them immediately. The mean survival was 18.3 weeks, range of 8 days. This is a patient with peritonitis, got a cervical cancer, and happened here, and to 40 weeks. A single patient was lost to follow-up, which is the last patient with a closed loop of bowel. Some of you may have helped me, this guy, that we have done it. The morbidity, pain, and enteropexy, 4 patients, periostomal cellulitis, 1 case, recurrent obstruction, this patient I've shown you, volvulus, which I don't know if it was a volvulus or not, because the patient always looked like a volvulus, and peritonitis, as I mentioned to you. So that for ileostomy. Moving to cecostomy, very tiny little thing. Indications are non-obstructive colonic dilatation, Ogilvie syndrome, neurologic, and colonic obstruction, distal to the cecum, not accessible for decompression by colonoscopy manipulation, dilatation of stents. All these procedures, these processes can be controlled endoscopically. So if they can't, then we can do a cecostomy. Technically, a cecostomy is a simple procedure. You have a target that is this big, Normally you have nothing between the abdominal wall and the colon, okay? So you cannot miss it, And this is the first case I've shown you, And this is another case that one of my colleagues in San Diego used the CT to do it, which I think is a super overkill. I think that it gives you opportunity to see how you're doing, how the process is going in real time. And here you can see the dilated cecum before the start. We talk, Alberto, they talk about 13 centimeters in the plain film as a risky thing to indicate decompression. Is that right? Okay, good. Well, and you can see here with this pigtail the decompression. So, in summary, effective percutaneous Jejunostomy and Cecostomy are effective procedures to achieve small bowel and colon decompression and reestablishment of oral nutrition in patients with chronic small bowel and distal colon obstruction. So the result definitely depends on appropriateness of the indication, correct technique, and follow-up management of these patients. These patients you need to get involved, but they will help you tremendously if you have an ostomy nurse taking care of them together with you. Okay? So, this is all. Thank you very much. And this is a bayou close to Long Lake. Any questions? Wake up! Hey!
So is there anybody else doing this?
Eh?
Is there anybody else doing this in the country?
I don't know. I don't know. We have a paper coming out. I mean, I have done this. It has been lagging behind publication. I presented it at the. I presented this at RSNA or SIR already. I presented this before coming here when I had 6 patients. But the issue is Axios, that tool that I show you, that thing is fantastic. Because then you can do colostomies, which is, as a matter of fact, cecostomy is a colostomy. Okay? What you need to do is to be able to bring the colon to the abdominal wall, which in the cecum is not a problem, but is a problem in other areas, including the transverse colon, because the transverse colon should be superficial. However, the transverse colon is attached to the retroperitoneum because of the mesocolon. So if you have a small bowel obstruction, you may have, the small bowel coming on top of the colon, and then you can, as you have seen here in a couple of patients, and it's really risky. This is, we are famous for hot sauces. Huh? They have funny names, that Amor, huh? And there are other names there. But the funniest name is this that is done in Meteor. This is Bayou Butt Burner. and this is for you, Alberto. It's done in Meteor. Screaming Sphincter hot sauce. Anyway, well, thank you so much.